Welcome back to the Deep Dive. Our mission today is to cut through the noise and deliver the highest yield knowledge available, custom tailored for you.
And we are diving deep into a topic that's often seen as separate from general medicine, but is really its absolute bedrock, medical psychiatry.
We're using Chapter 31 of Davidson's medicine as our guide today.
That's right. And this isn't just theory for an exam. This is truly foundational knowledge, the core principles, the assessment methods, and the crucial safety anchors that you, as an early medical student, really need to build your practice on.
Okay, let's just jump right in, starting with the big picture. Historically, medicine has put up this wall between mental illness and physical illness.
It has,
disorders of thinking or emotion on one side and everything else on the other. But our source material just dismantles that idea.
It really does. That separation feels more and more arbitrary. I mean, look at conditions we used to think were purely psychiatric, like schizophrenia. Modern research is constantly finding these, structural changes, biochemical abnormalities, complex genetic links in the brain. It's not just in the mind.
And the reverse is true too, right? We now know how much things like psychological stress affect conditions we see as purely physical, heart disease, IBS.
Exactly. We're treating a single unified system, not two separate patients in one body.
And the cost of ignoring that unified system is just staggering. To anchor this point for you, think about the global impact. Mental, neurological, and substance misuse disorders are the leading cause of years lost to disability worldwide.
That's a huge number. We're talking about almost 20% of all global functional impairment, nearly a fifth.
A fifth of all disability.
And here's where it gets really practical for you on the wards. If you just narrow in on the most common things, anxiety and mood disorders, they alone account for over 10% of global disability.
So the conditions you are guaranteed to see day in and day out have this massive cumulative impact. A quick prevalence check from box 31.2 in the text shows why your clinical setting matters so much.
It really does. In the general population out in the community, depression and anxiety are the major players, over 10% of people. Psychosis is rare, less than 2%.
But the second you step onto an acute medical ward,
the whole picture flips. Suddenly, organic disorders like delirium become incredibly common, especially in your older, sicker patients. And then if you go into a specialist psychiatric service, the base rates flip again. And that's where you'll see a higher concentration of psychoses and severe mood disorders.
Understanding that differential based on where you are is so key.
It's vital. And today, we're going to use that fundamental biopsychosocial framework, the BPS model, as our main tool to analyze everything.
Perfect. So let's connect every diagnosis and treatment back to those three core domains. All right, let's dive into the assessment process. In general medicine, we're so used to relying on labs, imaging, physical signs. How does evaluating a patient with a suspected psychiatric illness, how does that diverge?
Well, the basic structure is the same. History, examination, investigation. But the importance, the hierarchy, it completely flips.
Flips how?
We rely much, much more heavily on the history of detailed observation than we do on, say, a blood test for the primary diagnosis. There are really three key differences you have to grasp.
Okay, what's difference number one?
The clinical examination, what we call the mental state examination or MSE, is integrated into the history taking.
So it's not a separate step at the end?
Not at all. You are actively examining the patient's thinking, their mood, their behavior, while they're telling you their story. It's not like palpating an abdomen after you've heard all the symptoms. It's happening simultaneously.
Okay. And difference number two?
The heavy, and I mean heavy, reliance on an informant history.
So talking to a relative or a friend?
Yes. If a patient's illness affects their perception of reality or their memory thinks, psychosis, mania, dementia, you simply must get information from someone who knows them well. That corroboration is non-negotiable for an accurate picture.
That immediately puts the human element front and center. The source outlines the aims of the interview, and it's interesting that the very first step is establishing a therapeutic relationship.
Because that relationship is what gives you access. You need to build trust before a patient is going to open up about something like self-harm or delusions. It's the key that unlocks the rest of the history.
So let's zoom in on that MSE itself. It's a systematic, objective assessment. Walk us through it, starting with what you notice right away.
Okay, so we begin with general appearance and behavior. Simple observation. Are they alert? What's their motor activity like? Are they fidgeting and restless? Or are they showing what we call psychomotor retardation?
Which is?
A profound slowing of thought and movement. It's very characteristic of severe depression. And in an acute setting, You must determine their level of consciousness. That's the primary thing that helps you screen for delirium.
Next up is speech.
Right. We're noting the speed, the volume, the fluency. You mentioned pressure of speech earlier, that rapid, almost unstoppable talking you get with mania. That's a classic sign we're listening for.
From there, we move to mood and affect. What's the distinction?
So mood is the sustained internal emotional state. It's what the patient reports feeling. You ask them and they say, I feel hopeless. Affect is the external observable expression of that emotion, what you see. Their face is flat, their voice is monotonic.
And you have to ask directly about anhedonia.
You must. The inability to experience pleasure. It's one of the two cardinal psychological symptoms of depression, and it's a question you can't skip.
Now, this is the really complex part. Thought. The source breaks it into content and form.
Yes. So content is what they're thinking about. Is their mind filled with guilt, worthlessness, hopelessness? Are there thoughts of self-harm? And you have to ask about that directly. Plans means intent.
Or is it the opposite? Grandiose thoughts.
Exactly. Do they believe they have special powers or unlimited wealth? That points you towards mania.
And thought form is about how the thoughts are connected. This is where you see the disorganization in something like schizophrenia.
Right. We look for things like loosened associations, where their ideas jump illogically from one topic to a completely unrelated one. But the most diagnostically specific findings are the abnormalities of thought possession.
These are the experiences that are so alienating for the patient, like thought withdrawal. What does that actually feel like for them?
They might say something like, it's as if someone is reaching into my head and just plucking my thoughts out, so my mind goes blank mid-sentence.
And clinically, you'd observe that as thought blocking.
Precisely. The flip side is thought insertion, the belief that alien thoughts are being planted in their mind, often from a specific source, like a satellite or an enemy.
And the most profound one is thought broadcasting.
That's the belief that their private internal thoughts are leaking out and being heard by everyone around them. Sometimes they feel it's being broadcast on the radio. Recognizing these possession phenomena is absolutely crucial.
This is a perfect bridge to abnormal beliefs and perceptions. Let's nail down the definition of a delusion.
A delusion is a false belief that meets 3 strict criteria. 1, it's inconsistent with their cultural background. 2, it is held with absolute, unshakable conviction. And 3, it remains fixed, despite clear evidence to the contrary.
So you can't argue them out of it.
And you must not even try. You'll just damage the therapeutic relationship.
Now, perceptions. Illusion versus hallucination.
Okay, an illusion is a misinterpretation of a real external stimulus. The classic example is seeing a coat rack in a dark room and thinking it's a menacing person. The coat rack is actually there.
And a hallucination.
Hallucination is a sensory perception, seeing, hearing, smelling something, in the complete absence of any external stimulus. The voices or visions are perceived as real and coming from the outside world.
And we have to repeat that important caveat from the source. Hypnagogic hallucinations, when you're falling asleep,
And hypnopompic ones when you're waking up.
are normal. They're common physiological events and not a sign of pathology.
That's such a high-yield point. So with all that in mind, let's pause for our first check-in question to really lock in that distinction.
Okay, here it is. If a patient tells you they saw a coat rack in the dark and thought it was a menacing figure, is that an illusion or a hallucination?
And if they hear voices criticizing them when no one is around, where is that experience perceived as originating? Think about it, and if you're not sure, just rewind a minute or so.
Right. The answer is that the coat rack is an illusion, a misperception of a real object. The voices are a hallucination because there's no external source, and critically, they are perceived as coming from the external world.
Perfect.
Okay, next up in the MSE, cognitive assessment. The source says orientation and serial 7s are the baseline for every patient. Why is attention, which we test with serial 7s, so fundamental?
Because attention is the necessary substrate for all other higher cognitive functions. If a patient's attention is impaired, which happens acutely in delirium or even severe anxiety, then all your other cognitive tests, like memory tests, are basically meaningless.
So you test orientation person, place, time, and attention first to see if you can even proceed.
Exactly. And if that quick screen raises a red flag, you need to reach for a standardized tool.
The source mentions 3. Let's compare them.
Okay. For general clinical use, the Montreal Cognitive Assessment, or MoCA, is fantastic. It's free, it's pretty quick, and it covers more domains than the older tools like executive function.
And the older one is the MMSE.
The mini mental state exam, yeah. It's the old gold standard. Lots of people know it, but it's copyrighted, which is a hurdle, and it's less sensitive for mild cognitive impairment.
And the ACE3.
The Addenbrook's cognitive examination. That one's more comprehensive. You typically see it used in a specialist memory clinic where you need a much more detailed profile of the patient's deficits.
Finally, we assess insight. And this is more than just the patient knowing they have symptoms.
Much more. A lack of insight is the failure to understand that one is ill and in need of treatment. This is a cornerstone of emergency and forensic psychiatry because it dictates whether a patient can consent to treatment or whether legal measures might be needed to keep them safe. It's highly, highly characteristic of acute psychosis.
Okay, now that we know how to assess a patient, we need to understand why these disorders happen. Let's anchor this discussion with the source's risk classification, using that great metaphor of the psychiatric fire.
I love that metaphor. It breaks it down into 3 parts from box 31.5. Predisposing, precipitating, and perpetuating factors.
So how does it work?
Think of it like this. The predisposing factors are the dry kindling, the stuff that builds up over a lifetime and increases your vulnerability. The precipitating factors are the spark or the match that actually starts the fire.
And the perpetuating factors.
Those are the things that keep the fire burning. A steady breeze, poor quality building materials, anything that makes it harder to put the fire out.
Let's start with the kindling, the biological factors. Genetics are obviously a huge predisposing force in disorders like schizophrenia and bipolar disorder.
They are, absolutely. The risk in first-degree relatives is significant. But we have to get away from the idea of a single schizophrenia gene. The source is clear that most of these disorders are polygenic.
Meaning multiple genes are involved.
Exactly. It's the combined, cumulative effect of many different genetic variants, each with a small impact, all interacting with the environment, that creates the susceptibility.
And what about structural changes in the brain? Are they always obvious?
Not at all. In most primary psychiatric disorders, the brain looks grossly normal on a standard scan. But in, say, Alzheimer's, you see widespread atrophy. In schizophrenia, studies often show subtly enlarged ventricles. They're subtle findings, but they confirm the organic basis of the illness.
Functionally, it often comes down to neurotransmitters. Dopamine, noradrenaline, serotonin. Can you give an example of how modern imaging has actually proven one of these chemical hypotheses?
Yes. The dopamine hypothesis in schizophrenia is a perfect example. We've known about it for a while, but PT scans have now shown that in untreated first-episode patients, there's a demonstrably increased dopamine synthesis capacity right in the striatum.
So you can actually see the biological mechanism at play.
You can see it. It's a direct confirmation.
And beyond the chemistry, what is advanced imaging like DTI and fMRI telling us about the brain's architecture in these diseases?
It's telling us it's a connectivity problem, an architectural problem. Diffusion tensor imaging, or DTI, maps the brain's white matter tracks the wiring. And studies consistently show reduced integrity in the tracks that link key emotional processing areas, especially in the limbic system.
So if the information highways for emotion are damaged, what's the clinical result?
It connects directly to the symptoms. Difficulty regulating emotion, controlling impulses, integrating complex information. These are the core features of mood, anxiety, and psychotic disorders. It makes perfect sense.
Let's move to the psychological and behavioral kindling. How does a person's early environment load the risk?
Childhood adversity, abuse, neglect, severe deprivation is a massive predisposing factor. The chronic stress of those early years literally shapes the developing brain and significantly increases the lifetime risk for almost every psychiatric disorder you can name.
Personality itself can also be a risk factor.
That's right. Someone with a very obsessional personality, very focused on rules, order, control, is more predisposed to developing OCD when they're under stress. And personality can also be a perpetuating factor.
Keeping the fire going.
Exactly. A patient with an avoidant personality will struggle to engage in therapy and will withdraw socially, which just makes the prognosis so much worse.
And specific behaviors can do the same thing.
Yes. Think of anorexia nervosa. A dieting behavior starts it, but it becomes a rigid, compulsive cycle that perpetuates the disease. Or in a phobia, the persistent avoidance of the feared thing is what maintains the anxiety. You never learn that it's safe.
Finally, the social and environmental factors.
Social isolation is huge. A lack of a close, confiding relationship is a key predisposing risk for depression, especially in older adults. Social support, on the other hand, is a massive protective factor.
And what about the match that lights the fire, the precipitating stressors?
These are the acute events that trigger an episode. Obvious ones are trauma triggering PTSD or a significant loss like bereavement triggering depression. It's rarely the only cause, but it's often that final straw that overwhelms a system that was already vulnerable.
Okay, that brings us to our next check-in question, which asks you to pull all these BPS elements together.
Here it is. If a patient has a strong polygenic predisposition to schizophrenia, but stays well until they start smoking high-potency cannabis heavily in college, what role did the cannabis play in this model? And what specific biological mechanism did it likely activate?
Think about the fire metaphor, predisposing versus precipitating.
The answer is that cannabis acted as the precipitating factor. It was the spark that lit the genetically predisposed kindling. The biological mechanism is that cannabis is known to increase dopamine turnover, which directly ties into the dopamine hypothesis of schizophrenia we just discussed.
All right, now we apply these frameworks to the common high-stakes problems you'll actually see on the wards. Let's start with a couple that really blur the lines between specialties.
First is delirium. We've mentioned it, but it's worth anchoring. It's an acute, fluctuating disturbance of consciousness and cognition. It's hugely common in ICU and in older patients, and you must always screen for it in anyone who is acutely unwell.
And the second one is alcohol and substance misuse. This isn't a niche psychiatric problem, it's a massive general medical one.
It really is. Up to a quarter of male patients on a general hospital ward in the UK have a current or past alcohol problem. Assessment is key. You need to quantify their intake ask about a typical week in units, remembering 1 unit is about 8 grams of alcohol.
How reliable are the lab tests like MCV or GGT?
They're only supportive. A raised MCV or GGT can suggest long-term heavy use, but, and this is a critical point, normal results do not exclude an alcohol problem. They're only abnormal in about half of dependent drinkers.
So you can't rely on them to rule it out.
Never. The clinical history is primary.
Let's move on to the classic symptoms of psychosis: delusions and hallucinations.
Delusions are classified by their content, which gives you clues to the diagnosis. Persecutory delusions, MI5 is following me, are the most common. You also see hypochondriacal delusions, grandiose delusions, and the most bizarre are nihilistic delusions.
What's an example of that?
The conviction that one is dead, or that one's head is missing, or that the world has ended.
The type of hallucination is an even more critical diagnostic anchor, isn't it?
This is a top-tier, high-yield clinical distinction. Auditory hallucinations, especially voices that comment on the patient's actions, or 2 or more voices conversing, are highly suggestive of a primary psychiatric disorder, specifically schizophrenia.
And what points you towards an organic or medical cause instead?
Hallucinations in any other modality: visual, tactile, taste, or smell. If a patient is seeing things that aren't there, your first thought must be an organic cause. Substance misuse, delirium, a head injury, or temporal lobe epilepsy.
So visual hallucinations should make you think medical problem first.
Every time. Then you assess for mood congruence.
You're checking if the psychotic symptoms match the patient's emotional state.
Precisely. If a patient is severely depressed and hears voices telling them they're worthless and should die, that is mood-congruent psychosis. It suggests a severe mood disorder with psychotic features.
And if there's no connection, bizarre delusions with a flat effect.
That mood incongruence points you strongly towards schizophrenia.
When you're managing someone in an acute psychotic state, what's the key communication principle?
Acknowledgement without collusion. You have to validate their distress. You can say something like, "I understand that what you're hearing is very real and frightening for you." But you gently avoid agreeing with the false belief. The phrase our source suggests is excellent. Sometimes when we are unwell, our brains can play tricks on us.
Okay, let's talk about low mood and depression in medical patients. We know it's common, 10 to 20% on medical wards, and the symptoms overlap so much with physical illness.
This is a huge diagnostic challenge.
Right.
You can't rely on symptoms like fatigue or sleep disturbance.
So what do you rely on?
You have to probe for the core psychological symptoms. The 2 absolute anchor points for diagnosis in a medically ill patient are anhedonia, which we've mentioned, and the negative cognitive triad.
Okay, remind us of the triad from box 31.18.
It's a negative view of the self, a negative view of one's life experiences or the world, and a negative view of the future.
How do you ask about that in a natural way?
For the self, you might ask, do you feel you've let people down or that you're a burden? For life experiences, do you find yourself dwelling on past mistakes? And for the future, the key question is, when you look ahead, how likely does it seem that things will get better? If they're negative across all 3, That's a strong signal for depression, regardless of their physical fatigue.
We also have to consider the organic mood disorders.
Yes, physical conditions that directly cause depression. Neurological ones like Parkinson's or stroke are classic.
Yeah.
Endocrine disorders, too, always check for hypothyroidism. And never forget drugs. Glucocorticoids are notorious for causing both depression and mania.
When you diagnose depression, the source is clear. You must assess suicide risk.
Absolutely. The myth that asking about suicide plans, the idea is just that, a myth. It's dangerous. Asking directly and compassionately is the only way you create an opportunity to intervene and keep someone safe.
On the other side of the coin is elevated mood mania, or hypomania.
Right. This presents as this infectious, high-energy state. They have a reduced need for sleep. They're overactive, impulsive, reckless. If it's severe, full-blown mania, it can involve grandiose delusions and become a medical emergency due to the risk of exhaustion and dangerous behavior.
And finally, a common presentation: self-harm.
Right. Self-harm is a presentation, not a diagnosis. It's often an overdose. The key epidemiological contrast to remember is that self-harm is more common in younger women, while completed suicide is far more common in older men.
And the goal of the assessment?
To establish the immediate short-term risk of suicide, you have to ask about planning, intent, whether they left a note. Admission is only for those with a clear, acute psychiatric disorder, a very high suicide risk, or who need medical monitoring. Many can be managed safely in the community with good support.
So, given that we've framed psychiatric illness using the BPS model, it makes sense that the treatment has to follow the same holistic approach.
It has to. Effective management has to address all three areas: the biological, using things like drugs and ECT, the psychological, with talking therapies, and the social, addressing things like housing and employment.
Let's start with the pharmacological treatments, the three main drug classes.
Okay. First, you have your antipsychotics. They're for psychosis, obviously schizophrenia, bipolar mania, but also for some organic states like delirium. They mainly work by blocking dopamine receptors,
Second, antidepressants.
which have a much wider use. Depression, sure, but also anxiety disorders, OCD, and even for managing some chronic pain conditions.
And the third crucial class:
The mood stabilizers. Things like lithium, valproate, they're the absolute cornerstone of managing bipolar disorder, both for treating acute episodes and for long-term prevention.
Okay, what about the physical treatments? We have to talk about electroconvulsive therapy, or ECT. It has a lot of stigma.
It does, but clinically, it has a very specific and important role. It's a proven, effective treatment for severe, life-threatening depressive illness, especially when a patient has stopped eating and drinking or has severe psychotic depression. It's done under general anesthetic with a muscle relaxant.
What are the main side effects a patient needs to know about?
The main one is memory disturbance, some retrograde amnesia for events right before the treatment, and some anterograde amnesia, difficulty forming new memories during the course of treatment. This usually resolves, but it's a key part of the consent process.
And then there are the less common treatments, like TMS.
Right. Transcranial magnetic stimulation and vagal nerve stimulation have a limited role in highly treatment-resistant depression. And modern psychosurgery is very rare and precise now, targeting specific tracks for severe OCD. Nothing like the old frontal lobotomies.
Now for the psychological therapies, let's start with the one that every doctor should be doing.
Supportive psychotherapy. It's just empathetic listening, providing clear information, addressing a patient's fears. It's a fundamental part of good medical care, full stop.
Beyond that, we have the formal models. Let's start with the cognitive and behavioral ones.
Okay, cognitive therapy, or CT, focuses on identifying and challenging those systematic errors in thinking, like the negative cognitive triad in depression. Behavior therapy is very practical. It's about changing unhelpful behaviors, like using graded exposure for phobias.
And the one that combines them is CBT.
Cognitive behavior therapy. It's the most widely researched and used therapy. It's first line for depression, anxiety, eating disorders, even for helping patients cope with psychosis symptoms.
The source also mentions a simplified version.
Yes, problem-solving therapy. It's a very structured, brief form of CBT that's useful for helping people in an acute situational crisis, like after an episode of self-harm.
And what about the psychodynamic model?
Psychodynamic psychotherapy comes from Freudian theory. It's a much longer, more intensive process that looks at how unconscious motivations from early life are causing problems now. It often uses the therapeutic relationship itself, the concept of transference, as a tool for insight.
And interpersonal psychotherapy, or IPT.
IPT is much briefer and more focused than that. It deals exclusively with a patient's current interpersonal relationships and conflicts. It's got good evidence for mild to moderate depression.
Okay, now we're going to apply all of these tools to the major diagnoses. Let's start with a condition that defines so much of modern medicine, dementia.
Right. The definition is key. A global impairment of acquired intellectual function, which is typically progressive and occurs in the absence of impaired consciousness.
Yeah.
The numbers are just staggering. 5% of people over 65, 20% of people over 85.
Before you diagnose dementia, the source is very strict. You must rule out the treatable causes.
You absolutely must. That means blood tests for things like B12 deficiency or syphilis, and brain imaging to exclude a tumor, a bleed, or normal pressure hydrocephalus.
Alzheimer's disease is the most common. What is the one pathology anchor we absolutely have to remember?
Three things. On a macroscopic level, you see brain atrophy. Histologically, the hallmarks are senile plaques made of amyloid and neurofibrillary tangles made of tau protein. But biochemically, the thing that drives our treatment is the massive impairment of cholinergic transmission.
And that cholinergic deficit explains the clinical picture.
It does. The defining early feature is the impairment of new information memory. They can't remember what they had for breakfast, but they can recall their wedding day in detail. Later on, you see apraxia, aphasia, and often anosognosia, a lack of awareness that they're even ill.
So the treatment targets that cholinergic deficit.
Exactly. The first-line drugs are cholinesterase inhibitors, donepezil, ribostigmine. They boost the available acetylcholine, which can slow the cognitive decline for a time. It doesn't reverse it, but it can help.
Now let's contrast that with frontotemporal dementia, or FTD. Why is this one so often missed?
Because it's a clinical trap. It starts earlier, often before age 60. And critically, it presents with profound personality change or language problems before significant memory loss.
So memory might seem okay at first.
Relatively, yes. The family brings them in for disinhibition, compulsive behaviors, terrible social judgment, or a progressive inability to speak, while their recall of a list of words might still be decent.
So the location of the damage dictates the symptoms.
Precisely. And this leads to the crucial therapeutic point. Because the cholinergic system is not primarily affected in FTD, the Alzheimer's drugs, the anticholinesterases, are ineffective and should be avoided.
And the third major type, Lewy body dementia, or LBD.
LBD is the most complex. You get dementia plus Parkinson's signs. But the two hallmarks are a dramatically fluctuating cognitive state. They can be lucid 1 hour and terribly confused the next, and a very high rate of visual hallucinations.
And there's a huge management trap here.
A huge one. LBD patients are exquisitely sensitive to antipsychotic drugs. If you give them an antipsychotic for the hallucinations, you can precipitate a catastrophic worsening of their Parkinsonism and delirium. You have to be incredibly cautious.
Okay, this comparison is so vital. Let's do a check-in to make sure you've got it. If a 55-year-old patient presents with profound disinhibition, compulsive behavior, and poor social judgment, but their memory for recent events seems relatively okay, what dementia subtype should you suspect?
And, crucially, why would you avoid the standard Alzheimer's drug?
The answer. You should suspect frontotemporal dementia, FTD. The key clues are the early onset and the primary frontal lobe symptoms. You avoid the cholinesterase inhibitors because the cholinergic system is not the primary problem in FTD, so the drugs won't work.
Okay, let's move on to alcohol misuse and dependence. It's important to be specific about what dependence means. It's not just heavy drinking. It's the narrowing of their drinking habits, the salience of alcohol over everything else, tolerance, withdrawal, and that subjective compulsion to drink.
Let's focus on the acute, life-threatening presentations, the withdrawal spectrum.
Right, withdrawal symptoms usually peak 2 to 3 days after the last drink. You get anxiety, tremor, sweating, maybe seizures. The most severe form is delirium tremens, or DTs.
And what defines DTs?
It's a combination of severe delirium agitation, confusion, classic Lilliputian visual hallucinations, and profound physiological hyperarousal, tachycardia, high fever, sweating. It is a medical emergency with a high mortality rate if it's not treated aggressively.
And how is that different from alcoholic hallucinosis?
The key distinction is the level of consciousness. In alcoholic hallucinosis, the patient experiences auditory hallucinations, often critical voices, but they remain in a state of clear consciousness. And it's not typically during the acute withdrawal phase.
And the most important indirect complication to know about is Wernicke-Korsakoff syndrome. This is a major safety alert.
It is. It's caused by thiamine or vitamin B1 deficiency. Wernicke's encephalopathy is the acute reversible phase. You have to know the triad. Eye movement problems like nystagmus, ataxia, or an unsteady gait, and delirium or confusion.
If you spot that, you can prevent permanent damage.
You can. But if you miss it, it can progress to Korsakoff syndrome, which is the chronic, irreversible state. This is defined by a profound, debilitating short-term memory deficit and the classic symptom of confabulation.
Where they invent stories to fill the memory gaps.
Exactly. Which dictates our management. The immediate, non-negotiable first step is high-dose parenteral thiamine, Pobernex. You must give it before you give any glucose. For the withdrawal itself, we use a long-acting benzodiazepine like diazepam and taper down slowly.
All right, let's tackle schizophrenia, which the source describes as a chronic neurodevelopmental disorder.
That's right, strong genetic links, but environmental factors like obstetric complications or heavy cannabis use are key triggers.
Let's focus on the acute presentation, the positive symptoms, and specifically those highly characteristic first-rank symptoms, or FRSs.
The FRSs are true diagnostic anchors. They fall into three groups: the specific types of auditory hallucinations we mentioned, the commentary or conversing voices, the thought possession phenomena, insertion, withdrawal, broadcasting, and delusions of control.
The belief that an external force is controlling your movements.
Yes. Together, they represent this fundamental breakdown in the brain's ability to filter reality.
But once the acute phase passes, the illness is really defined by the negative symptoms.
Right, and these are what cause the long-term disability: apathy or avolition, alogia or poverty of speech, a flattened affect, and social withdrawal, or autism. These deficits are what make it so hard to function.
Management is antipsychotics, which block dopamine D2 receptors. There are first-generation and second-generation agents.
The first-generation drugs like haloperidol are effective, but they have a higher risk of extrapyramidal side effects, or EPSE, dystonias, Parkinsonism, akathisia.
That awful inner restlessness.
Exactly. The second-generation drugs like olanzapine have a lower EPSE risk, but they come with their own problem: significant metabolic disturbances, weight gain, high cholesterol, increased risk of diabetes.
There are two absolute safety anchors here that every clinician must know. First is the drug clozapine.
Clozapine is a game changer for treatment-resistant schizophrenia, but it has a 1% risk of a life-threatening side effect, a granulocytosis, a severe drop in white blood cells.
Which means?
It means mandatory, regular blood monitoring is required for the entire duration of treatment. If you miss the blood test, you have to stop the drug. There are no exceptions.
And the second safety anchor, neuroleptic malignant syndrome, or NMS.
This is a rare but potentially fatal emergency. You have to recognize the clinical picture: high fever, severe muscle rigidity, autonomic instability, so a labile blood pressure and heart rate, and delirium with a very high CK level.
And the immediate non-negotiable step:
stop the antipsychotic immediately. This is a medical emergency that requires intensive supportive care. Delay can be fatal.
Okay, let's move into our final section on mood, anxiety, and somatic disorders. First, mood disorders. We know unipolar depression has a very high recurrence risk.
It does, over 90% after 3 episodes, which is why long-term prophylactic treatment is often necessary.
Let's compare the older antidepressants with the current standard.
The older tricyclics, or TCAs, are very effective. They block noradrenaline and serotonin reuptake, but they have major downsides: anticholinergic effects, cardiotoxicity, and the critical danger: they are lethal in overdoses.
And it was why the SSRIs took over.
Exactly. The selective serotonin reuptake inhibitors are much, much safer in overdoses. Their main side effects tend to be nausea and sexual dysfunction. But there's one major safety warning: serotonin syndrome.
What does that look like?
It's a state of neuromuscular hyperactivity tremor, hyperreflexia autonomic hyperactivity, so high heart rate, high temperature, and agitation. It can be fatal and happens if you combine an SSRI with another drug that boosts serotonin.
Okay, now for bipolar disorder. It's highly heritable. What's the cardinal rule when treating the depressive phase?
You must combine the antidepressant with a mood stabilizer. Antidepressant monotherapy in a patient with bipolar disorder carries a very high risk of switching them into a manic or hypomanic episode.
And let's talk about the highest stakes mood stabilizer. Lithium?
Lithium is incredibly effective, but it has a dangerously narrow therapeutic range. The target level in the blood is between 0.5 and 1.0 millimole in a ohm. You need regular blood monitoring to prevent toxicity. Long-term, it can cause hypothyroidism and kidney problems. And it is a known teratogen in the first trimester.
And what about sodium valproate?
Also effective, but it has a high risk of causing birth defects, particularly neural tube defects. It should be avoided in women of childbearing age unless there are no other options and there's a robust contraception plan in place. Next up, anxiety disorders. They so often present to medical services because the somatic symptoms are so frightening.
Palpitations, chest pain, dizziness.
Right. A classic is panic disorder. The patient has these repeated severe anxiety attacks and often thinks they're having a heart attack because the symptoms are driven by involuntary hyperventilation.
How can you demonstrate that to them?
You can actually ask the patient to hyperventilate deliberately for a minute. If it reproduces their symptoms, it's very powerful reassurance that the cause is physiological hyperventilation, not a heart attack.
The management is CBT and antidepressants, but let's focus on the big danger point, benzodiazepines.
They are fantastically effective for acute, short-term relief. But here is the critical clinical warning from the source. Because of the extremely high risk of tolerance and dependence, regular prescription of benzodiazepines must be limited to a maximum of 3 weeks.
Why is that rule so absolute?
Because tolerance develops so fast. After 3 weeks, the patient is on a path to dependency, needing higher doses just to feel normal, and facing severe rebound anxiety if they try to stop. It's a trap. Beta blockers like propranolol are a much safer option for the physical symptoms like tremor.
Okay, we've reached the part of psychiatry that can cause the most frustration in general medicine. Medically unexplained somatic symptoms, or MUS?
Right. These are symptoms that can't be explained by a physical disorder, and they aren't better explained as just anxiety or depression. Syndromes like IBS or fibromyalgia fall under this umbrella.
Let's distinguish between the two classic presentations.
First is somatization disorder. This is where a patient has multiple unexplained physical symptoms across several body systems. These are the patients who end up having countless negative investigations and even unnecessary operations, which is a form of iatrogenic harm.
And hypochondriacal disorder.
This is a persistent, irrational fear or belief of having a specific, serious, often fatal disease like cancer or HIV that persists despite all medical reassurance to the contrary.
The management principles here are so critical. How do you handle this without dismissing the patient's very real distress?
First, you take a full sympathetic history and do a proper examination. You have to show them you believe their suffering is real. Second, and this is crucial, avoid unnecessary investigation and referral.
Why? That feels counterintuitive.
Because every negative test just reinforces their belief that the illness must be something even more rare and sinister that the doctors are missing. It feeds the anxiety cycle.
And how do you explain the symptoms? The source says you have to give a positive explanation.
Absolutely. You must never say it's all in your head. You use the term functional. You explain it as a reversible disturbance of normal bodily function. You might say to a patient with IBS, chronic stress is activating your nervous system, which is causing the muscles in your gut to contract, and that is causing real physical pain. It's a scientific, non-judgmental explanation.
Finally, we need to differentiate these from the conscious production of illness.
Right. Factitious disorder, or Munchausen syndrome, is the deliberate production of symptoms to get medical care, driven by a deep psychological need to be in the sick role. Malingering, however, is not a psychiatric diagnosis. It's the conscious faking of illness for an identifiable external gain.
Like money or avoiding jail time.
Exactly. The motivation is the key difference.
Okay, time for our final check-in question. A patient frequently presents to the emergency room with severe, persistent abdominal pain, convinced they have a rare cancer despite multiple negative scans and even exploratory surgery. They refuse to be reassured. What specific disorder is this highly suggestive of?
And what management approach is critical to avoid in the long run?
The answer. This is highly suggestive of hypochondriacal disorder. The critical management approach to avoid is that reinforcement cycle of repeated, unnecessary investigations, which only serves to solidify their health anxiety. And with that, we have completed a very deep dive into the essentials of medical psychiatry. We've gone from the fundamentals of the mental state exam all the way through to the high-stakes safety protocols for our most powerful drugs.
We detailed those crucial clinical traps, the difference between the memory loss of Alzheimer's and the personality change of FTD, the danger of antipsychotics and Lewy body dementia, and the non-negotiable monitoring for lithium and clozapine. These are the memory anchors you need for safe practice.
The final synthesis has to be that the biggest takeaway is integration. Psychiatry isn't a separate field. It's woven into every part of medicine. Recognizing the physical symptoms of anxiety or depression prevents iatrogenic harm from endless, fruitless investigations.
And as one final clinical anchor, we have to mention the unique risk in women around childbirth. Puerperal disorders are common. 80% get the mild blues, but 10 to 15% get a significant postpartum depression. And critically, about 1 in 500 women develop a serious puerperal psychosis, which is a psychiatric emergency.
Which brings us to our final provocative thought. We've touched on the legal frameworks, the mental health acts, that give doctors the power and the duty to treat patients against their will when their capacity is impaired by illness.
And this forces us to confront a profound ethical dilemma that's at the heart of modern medicine.
How do we, as physicians, reconcile that foundational principle of individual autonomy and consent with our duty to prevent harm when a patient's illness has clearly taken away their ability to make a rational choice?
That balance between freedom and duty is a line you will walk every single day of your medical career.
It requires not just knowledge, but wisdom. To secure the knowledge you've gained today, we'd urge you to go back and review the definitions of the first-rank symptoms and the 3 parts of the negative cognitive triad right now.
Thank you for taking this deep dive with us. Until next time, keep asking those difficult questions and remain vigilant in your assessments.